granular as well because we're going to link the reflex itself to pathology, right? And talk a little bit more about that. Oh my gosh. All right. Um, okay, here we go. Okay, guys. So we talk about obviously reflexes. We know, right? If we remember this, we know that essentially the deep tendon reflex, right, when also called the myotactic reflex, it's a pretty simple mechanism physiologically, right? So at least at first glance, but there's actually a lot of moving parts in regards to um, the physiologic and mechanisms involved, right? And the deep tendon reflex receives input and has essentially um, you know the Golgi tendon organ, both intrafusal and extrafusal muscle fibers, which we'll talk about, right? And then interneurons uh, as components, right? To the reflex itself, and so those are things that we're actually going to describe today. We're going to talk about what each one of these things are and how they actually have an impact um, on on the reflex itself, and how they govern the response. Okay, so let's first and foremost start talking about the GTO. So when we do a deep tendon reflex on a patient, right, we know that what we're doing is that we're actually tapping on the tendon, right, and then after tapping on the tendon, we see basically a jerk, right, and or twitch of the muscle. Okay, now within each tendon, right, there is essentially a Golgi tendon organ. There are several Golgi tendon organs inside of each tendon, right? But it's a proprioceptive organ, right? And it's essentially a bundle of collagen that's innervated by a type 1B nerve fiber. Okay, and that's a sensory fiber. So the job of the GTO is to sense differences in tension, right? And so a lot of times, right, that can be due to maybe a load placed on a tendon, like when you're working out, maybe lifting weights. But in our case, okay, we're using an instrument like maybe our fingers and or a reflex hammer to make the tendon stretch, right? So we are actually using the hammer, we're tapping the tendon, right? And as the tendon begins to lengthen and stretch, okay, the GTO senses that there is a difference in the length of the tendon, right? So it senses a difference in tension. Um, Now, in the event that those differences in tension are large enough, right, that causes a muscle contraction to essentially uh, happen, right? So it causes the muscle to contract to stop the tendon from lengthening any further, right? So there's almost kind of like this protective mechanism, right? That we don't necessarily want the tendon to lengthen to the point where it might, God forbid, tear. So the muscle itself contracts to stop the lengthening of the tendon, right? And that's where we get that classic, obviously, jerk, upward swing of the leg after tapping the tendon. Same thing with our bicep tendon reflex, right? With our brachioradialis, right? Achilles. So when you think about what we're doing, for example, even with the Achilles, we're putting the patient in slight dorsiflexion, right? So we're increasing length, right? And then we're giving the tendon a little tap. So when we do that, okay, we're increasing length even more. And in order to stop the stretch, we have this downbeat into the hand, right? With the Achilles reflex. Okay. Um, so that is the basic function of the GTO, particularly as it pertains to deep tendon reflexes, right? Okay, muscle fibers. And if I'm going too fast, guys, please stop me. This, we it's easy to get kind of into the weeds and kind of super granular on this. But let's just kind of we'll just stick to the basics. But if you have questions, please let me know. Okay, so when we talk about muscle fibers, right, we have two types, right? They can be extrafusal or intrafusal, right? So if you were to just look right at a muscle anatomically, maybe under a dissection, right, you would see you would essentially be looking at the extrafusal fibers, right? Those are the striations in the muscle, right? Now, microscopically though, right, inside of the muscle, right, each one of those fibers actually you know if we were to essentially kind of cut it open, right, we would see these interfusal fibers within the muscle fiber itself, right? And those interfusal fibers, so those are actually heavily innervated, right? And those are muscle spindles, right? And we'll talk about these kind of more in a second. But the bottom line is that these muscle spindles are also um, they're also important in regulating changes in length, so stretch, right? And they actually regulate the length of a muscle, right? And so if they feel that a muscle is being overstretched, they will essentially send a signal to the spinal cord, causing the muscle to contract. Okay, so we'll talk about nuclear bag and nuclear chain fibers in a second, uh, and kind of how they're innervated and what their jobs are. Okay, all right. So here's the deal. All right, we're gonna get it. Let's get a little bit more detailed on interfusal fibers. So, like we talked about, just like the GTO in a tendon, okay, and a muscle, the job of an interfusal fiber is to sense stretch, right? So there are two. If we were to take right an interfusal fiber and essentially put it, and kind of look at that maybe microscopically, right? If we were able to do that, okay, we would notice, excuse me, that there's essentially two parts, right, to an interfusal fiber, right? On each end, excuse me, there's essentially a motor fiber, okay? And those are essentially called nuclear chain fibers. So nuclear chain fibers at the end, whereas in the middle, okay, we have what's called nuclear bag fibers, and those nuclear bag fibers are sensory. Okay, so at either end we have the motor fibers, so nuclear chain. In the middle, okay, we have nuclear bag fibers. All right. So now, obviously, we know that we have these, the sensory fiber in the middle. So if there is a lengthening or a stretch of the muscle, okay, that one A sensory fiber, so that nuclear bag fiber will actually sense the stretch, right? And it will cause the gamma motor fiber to fire, causing the muscle to shorten, right, and stop the stretch. So the bottom line, guys, is that these are protective mechanisms to prevent over lengthening of the muscle, right, and over lengthening of the tendon, right? Okay. So, and you guys, please, if I'm moving too fast, please stop me and ask questions. Okay, don't let that deter you. Okay, so here's the deal. What exactly happens, right? So we're using the example of a patellar reflex here. Um, so ultimately, what is it that's actually happening when we do it when we elicit a patellar reflex in a patient? Okay, so there are obviously at the level of the spinal cord. So we see obviously we have the tendon, right? That we tap the tendon that the GTO essentially senses stretch, right? And then ultimately we know that the quadriceps will contract, right, to stop tendon lengthening. But okay, what happens at the level of the spinal cord here? So we have that afferent sensory response coming in right at the essentially the dorsal horn of the spinal cord, right? Coming in and actually synapsing, right, with what are called inhibitory interneurons. Now, I'm going to pause for a second. I don't know if I can make this bigger. I probably can't. Um, but if you look real close at the slide, guys, the one thing that you'll notice here in this diagram, all right, is that there is actually a very small little blue interneuron here, okay, that leads essentially to the quadriceps, and then a longer interneuron here at the spinal cord that has essentially a motor synapse to the hamstrings. Okay, now let me ask a question. If we tap on the patellar tendon and we have a contraction of the quadriceps to stop the lengthening of the tendon, right, and the muscle, what muscle do you think we have to inhibit? What do you think we have to inhibit to allow that to take place? Just looking at this diagram.
The hamstrings?
Bingo, the hamstrings. So what happens, okay? What happens, for example, if we have essentially insufficient inhibition of the hamstrings during a reflex? What do you think that might look like?
Like a really jerky swing or not
Bingo.
smooth.
Exactly. Like a really jerky swinger, essentially kind of an interrupted or jerky pendulum, right? So you guys remember what my reflexes look like, right? Super brisk, and I don't actually complete a full, uh, essentially a nice full arc, right? Now, here's the deal, right? So ultimately with that inhibitory neuron, if that's working obviously uh, optimally, right, and it is normal, right, and there's no lesion there, ultimately we're going to see a nice deep tendon reflex, you know, with a nice kind of complete pendulum uh, and a relatively relaxed hamstring relative to the quad. Okay. Now, for example, let's say, for example, that ultimately we have a lesion, okay, in the spinal cord, and um, sorry for pausing so much, guys, but I'm thinking through this as I'm talking because I want to make sure that this is clear. Is anyone and the reason why I'm asking this question is that this is a really good time to kind of continue to further explain the difference between an upper motor and a lower motor neuron lesion. Is anyone still confused on that concept? Like, does that still over anyone's head? Like, you don't really know what to do with that.
Just to be clear, upper would be to the CNS, and then lower would be to the periphery, correct? In like the most basic form.
Correct, Bennett. Yeah. So when we talk about upper, we're talking about spinal cord up, right? And so, for example, right, if let's say somebody had a lesion along the spinal, along the, I'm sorry, along the corticospinal tract, right? That would always be upper motor. Why? Because it's a descending tract, right? That runs from the precentral gyrus, right, via the thalamus all the way down, okay, to the anterior horn of the spinal cord, right? So that's always going to be an upper motor neuron lesion. So, for example, let's say, all right, that someone has an upper motor neuron lesion, and therefore the inhibitory neuron to the hamstring, all right, is essentially, there's a lesion that's governing the ability of the inhibitory neuron to shut off the hamstring muscle. Okay, so we're kind of connecting the dots. What and like we just talked about, if there is essentially an inhibition to that inner neuron because of an upper motor neuron lesion, we're going to have an interrupted pendulum, right? Um, and probably noted spasticity and or even some clonus in the setting of a deep tendon reflex. A little bit of a jump, okay, and kind of an interrupted pendulum. Does that make sense? Or am I confusing you guys?
I thought it made sense.
Okay. All right. Everybody else doing okay? You guys are good? Okay. All right. Um, cool. Now, guys, like we talked about, right? So in the setting of obviously of pathology, so obviously we know anything that so an upper motor neuron lesion, so spinal cord to the brain, right, in that area, okay, that's going to cause us, some hyperreflexia and or even some clonus. We're going to talk about clonus too today, right? We'll kind of describe that a little bit better, right? So we also know, though, conversely, that compression of a local nerve root. All right. For example, let's say that we had compression of the L3 nerve root that controls innervation to the quadricep. Okay. In this case, right? What do you think we might see if there's essentially inhibition of the motor nerve to the quad in a lower motor neuron lesion? What might that make the reflex look like?
Want to be absent
It would be absent or diminished. Okay. Why does it make sense that that would be absent or diminished?
because like that nerve is like severed and like it physically can't travel to the spinal cord and back.
Okay. And yeah, so yeah, Severed is one word, or essentially that there is a lesion of some sort, right? That is essentially inhibiting the ability of that nerve to send signals, right? And as we kind of, continue to move through this material, we're also going to talk about, or essentially have a lecture over essentially mechanisms of neural injury. Like, how is it that actually a nerve um, becomes injured, right? Is it traumatic, neurochemical, these types of things, and we'll talk about that. Okay, but yes, you are correct, right? So, obviously, compression of a local nerve root, right, is going to lead to essentially a lower motor neuron lesion that may actually cause diminished and/or absent reflexes. So, more like lack of tone, right? Nice job, nice job. Okay, now to kind of review, guys, and like I said, I know that I'm kind of zipping through this. Um, so essentially, like with our reflexes, right? So using a hammer, we apply a passive stretch to the tendon. Okay. Um, and obviously with the GTO inside of the tendon that's going, and the interfacial fibers inside of a muscle, those guys, their job, right, is to essentially detect changes in length, right? And so they'll detect that change, and they will transmit a signal to the dorsal horn of the spinal cord, right, to essentially facilitate contraction, right, of the muscle to essentially stop the lengthening, right, to avoid damage to the muscle, to the tendon, right. So passive stretch uh, essentially sends a sensory signal to the GTO and the interfacial fibers, right, and then that'll transmit a signal to the dorsal horn, which essentially culminates in muscle contraction and essentially kind of arrest of the stretch. It'll stop the stretch. Okay. All right. Obviously, grading of reflexes, guys. So obviously, we've been over this in class. We've talked about this, right? And we know that we know how reflexes are graded, right? 0 to 4, right? But we've talked some about how to link them to pathology, but I hope, right, that after kind of talking through a little bit of this physiology, right, that we're able to essentially have a little bit more of an idea, right, about what it is, um, that essentially, how the exam kind of pairs up to the anatomy and physiology, right? So obviously 0 to 1, okay, we know grade 0 is absent, right? So ultimately, if we have hyporeflexia and or absent reflexes, right, we're potentially looking at more of a lower motor neuron lesion, right, due to local nerve root compression, right. We know that our twos are normal, right. So uh, 3, and guys, just so you know, also, I didn't list this here, but uh, you'll also even hear things in clinical practice described as there being maybe 2 plus, 3 minus, things like that. So you'll hear pluses and minuses applied, uh, fairly similar to manual muscle testing as well, right? So you may hear, even doing an exam, right, that if we're looking at the L5 dermatome, or I'm sorry, L5 myotome, for example, excuse me, and we see weakness with great toe extension, we might call that, just like grading a manual muscle test. You're going to grade that maybe 3 plus or maybe 4 minus at the EHL, right? We'll talk more about that, right? So grade 3, okay, brisk or hyperreflexive, possibility of an upper motor neuron lesion, right? Um, and then ultimately, obviously, grade 4 is a brisk reflex with more than 3 beats of clonus, right? And is indicative of an upper motor neuron lesion, right? So, and I don't think we have any questions about that because we've talked about that plenty of times. But in the event that that's still not clear, let me know. Um, okay. So what about clonus? Okay. What is clonus? So the bottom line, guys, and you guys have maybe seen this a little bit. So clonus is essentially rhythmic muscle contractions, okay, in response to applied stretch, right? So for example, if you think back to how you do an ankle jerk, okay, think about what it is that we're doing. So you put your hands on the metatarsal heads, stabilize the ankle, and you pull up fast. Okay, you pull up fast on the ankle in the dorsiflexion. And if someone has clonus, they're going to have that rhythmic beating, you know, the rhythmic contraction of the muscle. Based on what we've just talked about, right, with essentially inhibitory neurons, right, and upper motor neuron lesions, why might someone display clonus if they have an upper motor neuron lesion. Like, is that maybe more clear now than it was? And why do you think that might be the case? Shoot.
Not
Sorry,
sure about
guys.
that one.
Okay. All right. So, I don't, okay. So ultimately with an upper motor neuron lesion, okay, here's the thing. We know that we have stupid button. We have two sensory pathways that we've talked about. Okay. We have the spinothalamic tract and the medial limniscal tract that we've talked about. Those are our two sensory paths. Okay. We know, and we've talked about one motor pathway. What's the one motor pathway that we know that's fairly dominant that we've talked about? What's it called?
Corticospinal.
Bingo. Okay. Corticospinal tract. All right. So let's say that someone has an upper motor neuron lesion somewhere along the corticospinal tract, right? Maybe even at the level of the spinal cord. So let's say that we have someone that has, that we're assessing for clonus. We do an ankle jerk. What's happening to the Achilles tendon? Think about that for a second. Same physiology applies here. What's happening to the Achilles tendon?
It's being stretched.
Yes, it's being stretched. Okay. So the Achilles tendon is being stretched and it's lengthening rapidly. Okay. The GTO, okay, the GTO is essentially uh, sending a message, right, that says, oh my gosh, the Achilles is stretching way too fast. We need a muscle contraction to slow this down, right? So then what happens is essentially the dorsomedial lemniscal pathway shoots that up to the brain, up to the brain. The brain sends, a response back down through the corticospinal tract to the muscle that initiates a contraction and stops the clonus in less than 3 beats. Okay. However, however, okay, in someone, all right, that has an upper motor neuron lesion, okay, we don't have the ability to essentially send the message back down the corticospinal tract to inhibit, okay, the stretching of the tendon. So the only thing that we have that is essentially going to stop the tendon is allowing the tendon to essentially deplete its energy. Let me explain to you what I mean. Let me actually draw this out. Okay. I know that's probably confusing. So give me 1 second here and I'll actually explain it. Whiteboard. All right. Let's try this guy. Viewer. All right. We're going to do some really crude drawings here. Okay. Check it out. So imagine, right, that let's say, for example, that you have a rubber band. Okay. And you stretch that rubber band. Uh, Sorry, you guys are probably getting, I know Charlie can see the whiteboard. Um, can you guys all see it?
I can't.
Okay. Sorry, dudes. One
No.
sec. All right. 1 sec here. Control C. I'll put it in the chat real fast. Uh, right there in front of my face, per usual. All right. So if you guys look in the chat, the link in the chat on Google Meet to a whiteboard. There you go. You guys got it. Perfect. Yay. So I'm assuming you guys are all here. Yeah.
Yeah.
Awesome. Okay, check it out. So imagine for a second, right, that you have you got a rubber band, okay, and you stretch it and you shoot it across the room. At what point does that rubber band essentially expend all the energy that you applied to it?
When it's done flying.
When it's done flying and hits the floor. You got it. Okay, check it out. So with the same thing applies to a tendon. Okay, a tendon, right, when stretched, that has no other way to essentially regulate the amount of, its length, will essentially, it will, sorry, that guy, there we go. It'll essentially, the energy will shoot way up and then it'll drop as the tendon hits the ground. That's a really horrible drawing, but try that again. All right, so the energy will essentially shoot way up, right, and then it'll go right back down. Ugh. All right, now with a tendon, for example, let's say that we don't have, okay, we have essentially an upper motor neuron lesion, and the only thing that's going to essentially stop that tendon from essentially from releasing energy is essentially time. So ultimately, up, down, up, down, up, down, up, down, and the foot and ankle are going up and down, plantar flexion, dorsal flexion, beat, 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 and every time we go up and down, that tendon is depleting in its energy. I know this probably doesn't make a ton of sense to you guys, and I know this is probably kind of abstract, right? But this is essentially how that tendon, how that tendon loses energy. Okay, basically in a disease state, it'll just keep oscillating back and forth until the energy is gone. Okay, now each one of these beats, guys, is clonus. 1 beat, 2 beat, 3 beat, 4 beat, 5 beats, 6 beats, 7 beats, 8 beats, right? Now, in a normal situation, in someone that is healthy, right, they actually have the inhibitory motor neuron intact to shut down the rhythmic contraction, right, and relax the muscle. Someone that has an upper motor neuron lesion does not have the ability, or does not have the intact physiology to essentially create a muscle contraction to shut down the rhythmic clonus. Am I making sense? Or no?
I think so.
All right. What about, so ultimately, right? So I'll close this whiteboard and then we'll go back to the PowerPoint. Okay, so we know that someone with clonus obviously is going to essentially have these rhythmic muscle contractions, right? Due to obviously an upper motor neuron lesion, right? So there's different ideas behind the physiology around clonus. There are people that think that, or there are those that think that people that have clonus simply have obviously more excitability to those neurons due to increased or absent inhibitory function because of an upper motor neuron lesion. But we remember, right, that when assessing clonus, okay, anything more than 3 beats is abnormal, and when you feel clonus, that first beat's going to be the strongest, and then it'll gradually get weaker as the tendon kind of basically depletes its energy, right? So beat 1, strongest, 2, 3. Anything greater than 3 is abnormal, right? And so when you have someone with clonus, you'll have several beats, right? That will, the first beat will be rather strong, and it will eventually dissipate over time, right? It'll make more sense as we continue to practice. the neuro exam, but this is probably one of the more complicated topics that we cover in this class. Um, what questions do you guys have on this material? And I updated this, and I will add this to Moodle today as well. So, what questions do you have? Anything that's not clear? No,
I got nothing.
you got nothing. Okay. Does anybody think that this is difficult slash I don't really get this? And it's okay to say that.
I mean, I'm definitely gonna go over it 1 or 2 more times, but
Okay.
I think it's pretty understandable.
Beautiful. Okay. I will also put this on YouTube, and I can send that out via email to you guys as well, so you guys have that, the link and everything. Okay, you guys, that's it. So tomorrow we're going to do some work together on assessing cognition. We're actually going to sit down and we're going to go through some practical skills to assess cognitive function. Okay. Nice job. Okay. I will see you guys tomorrow. And if there's any questions, just holler at me.
See you tomorrow, Wade.
Thanks guys. All right. See ya.